Thank you, Artie, for the kind introduction and for the possibility to be here with you during the next 15 minutes, because I just actually wanted to show you a case which I treated, and Kevin also filmed the part of the treatment. And I just wanted to go over several steps which we will highlight. Just briefly, this was the initial situation. It was a steep bite, deep bite, class 2. So we did some small ortho first. This was then the situation after orthodontics. It's still kind of a tendency to a steep bite, so we wanted to change that. We wanted to change that restoratively. So therefore, we decided to intervene restoratively. There were done a lot of composite restorations in these teeth, and the patient would like to change them for ceramics. Although a lot of the restorations were on the palatal and on the labial surface of the teeth, they were not fully restored. So we decided to look for a way where we could try to do it as minimal invasive as possible. Well, when we first started, as you all know, we start with a DSD at first. So that's what we did. And with the DSD, we created a wax up. So the first step of it was to create a wax up. This was done in an analog way, like the old-fashioned way. But the wax up, we used it to transfer the wax up to the intraoral setting. So here you can see the upper jaw perfectly waxed up. Also trying to change, as you can see here, trying to change the inclination of the central incisors and trying to improve not only the aesthetics, but also trying to improve function, because that's of a major importance. Here you can see the mock-up in place. And with the mock-up in place, we use the Physalis temp here to try and visualize the new aesthetic situation that we wanted to achieve. We also tested the functional aspects here. So we try with a mock-up, we let the patient go in for about 4, maybe sometimes 6 weeks with the mock-up in place. So the patient can actually really have a try-in period with these temporaries. So after the initial plan or the mock-up was approved by the patient, we decided to go into the next phase. So when everything is going well, functionally, aesthetically, only then we proceed with the procedure. And up till now, up till this part, we didn't do anything yet. So we did not really intervene with the burr. We only added material, we changed the shape of the teeth, but we did not use the burr up till now. So if the patient does not agree, does not apply, does not want to continue with the treatment, nothing is wrong or whatever. We can just remove the mock-up and we're back to our initial starting position. So here we can see it from a little bit closer from the intraoral aspect. Of course, you can see these are temporary materials, but it still looks like very attractive, and the patient can really see from color-wise, shape-wise, and function-wise how her new teeth will perform and how the new teeth will actually function. Also from the side, here you can clearly see this is a different inclination of the central incisors. As you now look, we also addressed the palatal part. Therefore, we changed function and we changed the steep guidance, because initially there was a pretty steep guidance and a deep bite. Of course, we were not able to address the deep bite completely, but we could improve it in a major way. So here you can see it from the side again. And as you can see, color-wise and integration, although we did not apply the temporary material everywhere, you can still, this looks quite acceptable to test drive for several weeks. And here just a singular close-up from the anteriors. Then when we look to the occlusal part, you can see here now the occlusals. We changed the occlusal scheme in order to get better function. Now, after approval by the patient, we started preparing the teeth, and I decided to go here with a minimal invasive preparation, which is called the sandwich technique. So I prepared palatal backings and I prepared facial veneers. So first of all, we decide to use the grooves, depth grooves. Although on the palatal side, it's a little bit more difficult to create those depth grooves that you normally see on the facial. So we decided to go here with those palatal backings by lithium disilicate, but we still wanted to have enough thickness. So in order to be able to prep through the mock-up, I used just a round burr of approximately the thickness that I wanted to keep for my lithium disilicate, and then we started to prepare the palatal part. This is after preparation, removing the old composites, preparing the teeth, and then applying retraction cord and taking the impression, and so on and so forth. When the patient was having temporaries on the palatal side of the anteriors, I decided to build up the posteriors by hand. So I used direct composite, which I transferred from the wax up to the shape of the teeth. First of all, we removed the old composites, and then we build it up with composite freehand. So this is not in the original occlusal scheme, but this is in a new elevated vertical dimension of occlusion. Then after changing the posteriors, the molars, we got the palatal shells back from the dental technician. Remember, this is lithium disilicate, it's monolithic lithium disilicate due to strength, and we decided to cement them in one by one. Or I have to say in pairs. I prefer to do the two centrals at once, and then the lateral and the canine. So this is after cementation. And immediately after cementation, this is how it looked. I decided then to continue with a buccal preparation for veneers. So here you can actually see not much changed. We changed the occlusal scheme on the palatal side of the anteriors, but we did not change the aesthetics yet. So what did I do? I entered again the mock-up. So we applied the mock-up again, and we used then the traditional depth grooves in order to reduce the amount of material needed for the space for our restorative materials. So in order to obtain enough space for the lithium disilicate. And this is then after prepping the anteriors. You can see I prepped from 5 to 5, so the 10 anteriors were prepared. And also old composites were addressed. Now this way I was able to keep the positioning of how you position the restorations, both 100% from the lingual and 100% from the buccal. So this is then after preparation. You can see we tend to pay a lot of attention for the soft tissue because this is immediately after preparation, and I tend not to damage the soft tissue with a burr in order to keep it as clean and neat as possible. So then after preparation, we applied the retraction cord. I like to use a double cord technique, of which I place 2 cords. 1 cord I remove before taking the impression, and the second cord then comes with the impression sometimes if we are lucky. And here you can see we have a very nice and clear impression using the double cord technique. So then the temporaries, I will show you in the video later on how I exactly create the temporaries, because here I use a 2-stage technique in which I use the silicon matrix in order to create the coronal part of the temporaries, and I use a flowable to create the cervical part of the temporaries. So let's have a look on the video, and let's have a look what I do exactly to get my analog impression. So I use an impression technique which creates an individualized tray with the Panasil putty. Then I take the mock-up again. With the Visalis stamp, I do the depth cuts. I mark the depth cuts in order to see how much material I still need to remove. Because if there is pencil left, that means that I need to reduce the thickness there. So therefore I'm using it. As you can see, I work under a microscope, and I use the drills here in order just to set the margin. Remember, we have the initial entry of the restoration in this part could be completely from the buccal part. So we do not mind, we can position the veneer from buccally. So then the finishing, I start normally with a normal diamond, then we finish up with a red diamond, and then after preparation we put in our retraction cord. First it's a 0, or sorry, a 000. And this is the green retraction cord, and I place them one by one. So each tooth has an individualized retraction cord. Then we get to a full length retraction cord, which goes continuously to all the different teeth. Now you can see I'm applying the impression paste, but I'm in the same time I'm removing my retraction cord just in time, so I can immediately catch the sulcus. I can immediately catch the impression. So then after that we also take a bite impression, of course, And then it's time for my temporaries. Here you can see I cutted the silicone index just halfway, just at the contact areas. So I only created my incisal part. The rest I will do it with flowable. Why do I do that? That is in order to make sure that I will not catch the papilla inside of the temporary material. Therefore, I'm using the Visalis flow just to create a nice adaptation. So this is the delivery of the temporaries. Then we get the cementation of the veneers. So it's about 4 weeks later that we have the veneers. And I needed to etch with fluoric acid the palatal part of my lithium disilicate. Because remember, palatal is lithium disilicate monolithic and the buccal is feldspatic veneers. Here I'm using just floss to check, and I place them two in sets of two, so two the centrals and then the premolars, where we use the Visalis material. Then after placing the restorations, we need to do some minor adjustment. We finish, we polish, and then finally this is how we end the case. This is a 2-year follow-up. This is how we end. I think, no, sorry, this is immediately after treatment. And I need to look at, yes, this is immediately after treatment. And here you can see the combination. So the palatal part is monolithic lithium disilicate and a buccal part with feldspatic veneers. And this is the final smile. Probably this is, I think, yes, this is 2 years follow-up, where you can see the soft tissue is even more integrating with the restorations. So this is from the buccal point of view. And this is where, if you really are working with high magnification and precision, you see a beautiful adaptation of the soft tissue. And this is then from the occlusal part, as you can see, and just one more close-up. So I want to wrap up with this with a final smile, because actually this is probably where we do it for, where we do our hard work for, in order to have those nice results and big smiles of our patients. So thank you for your kind attention.